Hi, everyone. I'm Emily Marsh from the Greater Concord Chamber of Commerce. Thank you so much for joining us for our webinar this morning, partnered with Concord Hospital. I'm so glad that Dr. Fore is here to answer some questions and join us today. I just want to quickly go over some information before we get started. We do have limited time as this is a 45-minute webinar. But there will be a Q&A session, so don't worry, you can ask questions. If you are a business owner or employee or community member who has questions, and needs resources during this time, please utilize the Chamber of Commerce's website. If you go to our homepage at concordnhchamber.com, you'll see a link to a special COVID-19 resource page. And from there, you can access a lot of really helpful information. We update this constantly, so there's always new resources for you to take a look at. As well as recorded webinars like this one. It will go online later today. So before we get started, I want to explain to you how to use our Q&A feature. If you tap your screen or move your mouse a little bit, you should see a button that says Q&A. And if you open that up, you can simply type a question. That question can be viewed by our presenter, and we'll hopefully get to all the questions. We may not be able to answer everything, but we will do our best. So again, if you have a question, the way to get that answered is to use the Q&A portal within Zoom. So without further ado, thank you so much to Concord Hospital, and thank you, Dr. Fore, for being with us here today.
So good morning, everybody. Hope everybody's feeling well this morning. By way of introduction, my name is Chris Fore. I'm the Chief Quality Officer at Concord Hospital. I'm also the Associate Chief Clinical Officer over the inpatient and acute care space. So the reason I'm talking to you this morning is obviously because of the national health emergency related to COVID-19. This is obviously quite applicable to our region as well. And also because about 15 days ago, I received a call from the state of New Hampshire asking if we would be willing to stand up a surge site at the New Hampshire Technical Institute, which is part of the community college system of New Hampshire, to make sure that we could provide and execute on the essential mission of providing patient care in the capital region, more specifically with member healthcare institutions to include Concord, LRGH, and Franklin. We said yes. We were already quite concerned about the possibility of a surge. We're all hoping that that surge of patients that will exceed capacity of institutions won't happen. However, although we hope for the best, we wanted to prepare for the worst. So we began in earnest in planning. So perhaps what I'll do is actually walk you through a couple things, and then really I'd like to leave a lot of time for questions and talk about what's on your minds as local business owners and leaders. So on the hospital side, we have for the past 6 weeks, really nothing has been normal. We have been spending significant amount of time and effort really planning this. We've gone about essentially a facilities transformation. Prior to this epidemic or pandemic, we had about 20 negative pressure rooms that would be appropriate for someone in airborne precaution, someone with a aerosolized or airborne spread viral pathogen. That was pretty typical for a hospital that normally has a capacity around 230 individual inpatient spaces. We've now increased that number to 80 individual patient spaces with negative pressure that can allow us to use airborne precautions. That took a huge time and effort, and the facilities operations team did a great job. I know our partner to the north, LRGH, now has the capacity to place 39 COVID positive patients in their institution, which was certainly a big stretch for them as well. We have begun to plan of how we would meet patient demand, realizing that failure was not an option. We have developed staffing contingency matrices. We have ended all elective surgeries. We have pulled back personal protective equipment given the shortage from all peripheral sites and located them strategically in central locations and have centralized the distribution and accounting of personal protective equipment. We have stood up and have been continuously running an incident command structure during this period for the last 6 weeks. We've also been running a separate incident command structure here at the New Hampshire Technical Institute for 15 days now to prepare this site, with the goal of actually consolidating all communications through logistical operations and communication chiefs to make sure that we're all on the same page and to make sure that the compass is pointing in the same direction at all times. So lots of work has been done. We have, I can talk about a couple of things on the community side as well worth mentioning. We've actually stood up 2 drive-through testing sites for members of the community to be able to support testing to the extent that it's available. There are some resource constraints with testing that we're all aware of. We also have the same resource constraints here locally, but we are attempting to do that testing in the safest method possible. And the drive-through testing was something, the planning efforts began on a Monday and it was executed by 10 a.m. on a Monday morning. And we're pretty proud of that effort. I can transition into the tech now. So when we received the call from the state 15 days ago, we committed ourselves to this project. We actually showed up at the tech at 3 p.m. on a Friday afternoon to assess the site. I think everybody at the tech was somewhat surprised that we were here. And what happened next is we essentially went into a 7-day week operation that is still not complete. However, we got to working through that first weekend, the second weekend, to really set up the site. This was a partnership between multiple stakeholders. I can't say enough about the participation of the 2 healthcare systems between Concord Hospital and LRGH Healthcare, also the state of New Hampshire, also the public health networks from the Winnipesaukee area and the capital area, also to include the New Hampshire Army National Guard, and our partners here at the Tech, which is part of the community college system of New Hampshire. Of particular note, the facilities operations crew, the maintenance crews, and the executive management team of the CCSNH have really been exceptional. They truly are the unspoken heroes of this effort and have transformed a college campus on the banks of the Merrimack River here in Concord into a field hospital in very little time, and have just been really exceptional partners. I can't say enough about that. So in terms of the scope of the hospital, when we were asked to participate in this and to stand this up, we were really given a clean slate. They asked to assess what we thought our system or regional needs would be, and then create the field hospital to really support that critical need. And honestly, 3 things came to mind immediately. The first thing that came to mind before those 3 things was the fact that we acknowledge the fact that people that need to be in an acute care hospital need the level of support of being in the hospital, need to be in that hospital, and would not be best served being treated in a gymnasium or a conference center or something where we were attempting to stand up critical care in a civilian space is not well suited for that. So what we needed to do was be able to displace people of moderate and mild illness out of the hospital so that we can take care of the sickest of the sick in the location best suited to do that. So that was really a fundamental assumption number 1. Fundamental assumption number 2 was that we recognized that an offsite facility would be very difficult to manage if you had 2 different populations of patients you were attempting to serve. So if you had COVID positive patients or COVID negative patients, that you would have to be very, very careful, and you'd have to go to great lengths to make sure that you weren't putting COVID negative patients at risk by being cohorted with patients on the same location with positive COVID. We also recognize that there's a large population of people who are presumptive positive or pending testing. Those patients have a test which has not yet resulted. This is currently taking anywhere between 48 to 72 hours. We also recognize that's a third population that you have to be very careful with. The last thing you would want to do is place patients who have pending testing in a site that's all COVID positive, realizing that would be the highest risk location for someone who may end up not having COVID at all. So with those 3 fundamental assumptions, we went about deciding what populations would be most in focus. And the rundown goes something like this. So the first population that's clearly in focus are people that do not meet criteria for acute hospitalization. They have some degree of illness, but would not need to be in an acute healthcare facility to be cared for. But we recognize there's a substantial part of the population that would not be able to safely or independently self-isolate. So this could be a person with social vulnerabilities who literally does not have another place to seek a safe harbor if they are positive. We also recognize that families may have individuals at particular high risk. If you live with someone who's at advances of age, is immunosuppressed, has undergone recent cancer therapy, has underlying interstitial lung disease, something that would make them high risk to COVID, that's a population. Those things oftentimes can be sorted out within the community with a course of a couple of days, but oftentimes at 2 a.m, that's very difficult to sort out if you don't have a safe place to go right now. The second distinct population would be patients or residents that come from long-term care facilities. The capital area in particular has the highest concentration of long-term care facilities in the state. We recognize that in an attempt to keep patients who are COVID positive out of long-term care facilities, it would be important to provide a place for those patients to be safely cared for. We recognize a lot of these patients may meet criteria to need to be in the hospital, but some of them may be doing okay or may be convalescing from the illness after a stint in the hospital and would need a place to go that would not place patients in residential facilities at increased risk. We recognize that's a moving and dynamic target because local long-term care facilities have risen to the occasion and are actively planning how to cohort patients even within their own facilities. However, we recognize this could be a real systems constraints for acute healthcare. Between Lakes and Concord, we have 111 appropriate negative pressure spaces in the institution, which is very, very important if you're in the hospital. And we recognize you could quickly go through that with the number of long-term care facility residents who are in the area. So that's a summary of the second population. The third population are patients who are at the end of life. They are in end of life status or hospice status or comfort measures only. These would be patients who have expressed a wish not to have aggressive healthcare or escalating, increasing medical resources used on them. Those patients would also need a place to go to undergo hospice if they could not safely return home or could not safely receive that care in a long-term care facility or a hospice house formally because of a COVID positive status. So this is something that we think has to be done exceptionally well. We've had a lot of planning efforts surrounding that population, to including members of palliative care teams, hospice care teams, and the Concord Regional VNA are our partners in that, as well as the Concord Hospital Medical Group and the medical staff. So those are really the three populations. The first bucket being those with social vulnerabilities, the second bucket being patients from long-term care facilities, and the third bucket being patients who are at end of life and really need to be able to receive that care appropriately and to have that well done, but don't have a safe place to go because they're COVID positive. The site itself is split into two sides. So on the Tech campus, if you're familiar with it, there's a number of dormitories. So Langley is the name of the dormitory that is just across the street from Sweeney Hall, which is adjacent to the Wellness Center. Sweeney Hall would allow us to put 125 long-term care facility type patients into single occupancy rooms with temperature and humidity controlled environment, pretty good plan for ventilation with window fans and engineered airflow design in that facility. That facility could surge up to 175 patients if we really needed it to, but it would comfortably serve 125 patients. On the side of the street where I'm sitting right now in Sweeney Hall, we have the gymnasium, which is set up that could actually surge as high as 115 patients. This would be our last resort. Given this will be the hardest facility to staff, we think that providing some degree of medical care in a gymnasium will be a real stretch, but could be potentially required. So we have set up the gymnasium in partnership with the state of New Hampshire, the Public Health Networks, and the Army National Guard with cots. electrical supplies, HVAC and ventilation, in case we need to do that. So those are really the two sites. So if you kind of add the numbers together, we really could surge to 300 patients. We're really sincerely hoping that we do not have to surge to 300 patients, but we are planning to be able to do so if it's required. So with that preamble and background to it, this is probably a good time to take some questions. So if I can figure this out, I'm going to flip over to the Q&A and start to work through some of these. First question is, what is the timeline for the surge site at the tech? Can you talk about how the decision will be made and when to wind it up, wind it down, and who will make that decision? So that's a great question. Unfortunately, that person who makes the decision is me. We have design triggers from a capacity assessment standpoint on the hospital side. We are currently using a target of, we will turn this facility on when we have actually reached 75% of capacity of ability to house COVID positive patients in Concord Hospital, LRGH, and Franklin. So that would be 75% of 111 beds. So probably just under 80 patients in 111 potential spaces. Once we push what I'm calling the red button, we will have 48 hours to spool the facility up from a staffing standpoint to turn on all the infrastructure that allows us to safely take care of patients here, and start to take transfers. We would accept transfers during daytime hours, actually more than daytime. It'd actually be 9 a.m. to 9 p.m. in an attempt to allow us to staff down a bit at night, given that staffing will be a significant constraint, given this would also be occurring during a time of overcapacity and surge at the hospitals we serve. We would start to wind it down when that trigger was met in reverse. So once we got below 75% capacity in the hospital, we could foresee beginning to transfer patients back to the hospital, but it's also quite possible that the operational length of this project could be 3 months or perhaps longer as we begin to appropriately place patients back into the community, back home, back into end of life facilities, or back into long-term care facilities. So that's a great question. Second question is, where might be the biggest resource deficits that you have seen during this project or during this pandemic? That's a great question. So thanks, Donna. I would say the biggest resource constraint that all of us are feeling is personal protective equipment. So currently, at an institutional and enterprise level at Concord Hospital, we currently have what we feel are adequate PPE resources, and we have calculated run rates and burn rates for PPE, both for this facility and on the hospital side. What we do know, however, is everybody, our system currently has a 14-day supply, perhaps a bit more, of PPE. There is, however, an unsettling feeling that if there was some disruption to continued supply chain, that could be a real resource constraint. That is certainly something all of us have heard about in the news nationally and regionally, and something that continues to concern us. We do have a good partnership with the state of New Hampshire and the Department of Public Health and DHHS. And I do think we're going to rise to the occasion, be able to serve the mission, but that's certainly a resource constraint. Probably the other one I would mention is just the time needed to spool this facility up has been compressed given the escalating pandemic to our south. So time was a significant constraint. And I think the third constraint I would mention would be concerns about being able to staff the facility. So we have had a number of volunteers. We currently feel we have a staffing plan that's sustainable. But as the institutions that we serve ramp up in numbers of patients and acuity of patients, we will certainly start to feel the pressure. And we can only hope that our workforce stays well and healthy and safe, because that will also cause concerns as well. All right. Third question is, when the New Hampshire curve is reduced, what can businesses do to keep their patrons and themselves safe? So that's a great question. I would say there's a lot of guidance out there. I'd say that there are three major sources of information regarding guidance for prevention of infection spread. First is from the CDC, second from the White House Task Force, and third is from state and local authorities. I would say at this point, it does appear that we are flattening the curve with closing of non-essential businesses. And we know that that has hurt everybody. We do believe that physical and social distancing has helped. We know that self-isolation has helped. We know that the ability to test has helped. It does appear that we're flattening the curve. In fact, the major predictors and people who are working computer models of disease indicate that we're probably not going to fall short of ICU beds or ventilators in the state of New Hampshire, but I think that's all contingent on the current trajectory of containment and flattening that curve. So I would say my best advice to everybody is to wear a mask everywhere you go. If you're not by yourself, put on a mask. Wash your hands, use hand sanitizer. Don't go anywhere that you don't need to go. And don't be the next host and spread the disease. So be hyper vigilant about where you're going and why you're doing it. And yes, in my family, we talk about that around the dinner table every time someone wants to go to the store. And we describe why that's not a good idea. All right, next question. Please describe the future local procedure for antibody blood tests. Would this be done with drive-through testing? So the antibody testing, there are actually, to my knowledge, as of this morning, 2 antibody tests that have received FDA approval. One was by a biotech firm out in the Denver area, one in Raleigh-Durham, the Research Triangle area. I do believe that the antibody test will be critical and probably will end up being more important than the RNA PCR test that we're doing to make a diagnosis. And I think it has a couple advantages, and I think it will be critical, especially when it comes to healthcare providers. So the RNA PCR test really just defines, do you have virus replicating in your system? We still don't know the sensitivity of that test. I think many of us share concerns that the sensitivity is not particularly high, probably somewhere around 70%, which means 30% of people who test negative could have the disease, which is certainly concerning. That number I'm putting out there, 70%, has been widely talked about, but we're not actually aware of any conclusive studies indicating that's the actual number. Once you have an antibody test, however, you can definitively prove the person has actually mounted an antibody response to the disease, and it would help you to identify people that are in a convalescent stage and much safer to return to work, return to the community, and return to the front line in healthcare. It would also help you pool donors to potentially pass on that passive immunity through plasma donation to patients who are critically ill. So I do think that the antibody test could be done in a drive-through testing format, although most of the time people are no longer sick and could be safely done even in lab draw stations potentially. That's a great question. And if someone out there has a connection to get the antibody test in New Hampshire sooner, please call me today. All right, next question. How do you feel New Hampshire will align with CDC's model projection for infection mortality? I think we are probably going to stay on course for the projected mortalities. There is an organization out in Washington State whose name is escaping me right now. It's a 4-letter acronym. I want to say it's ISME, Institute for Simulated Medical something. They are currently doing modeling, pretty predictive modeling at the state level, also the national level, and some international sites. Right now, they are predicting that the peak of cases in New Hampshire will still happen in the 3rd week of April. If that is the case, and we continue to self-isolate and we continue to contain the disease and we continue to stay at home, I do think by the time we get to the end of April, we're going to be in a good place. And I think we will do much better than our predicted mortality and morbidity. Okay. Next question is, one of the hazards of a successful containment effort might be public skepticism that the stringent social distancing was necessary. How can public leaders respond to this? So that's a great question. So this is something that was honestly irritating me to no end a couple weeks ago, because the way this disease works and the way pandemics spread is you're spreading the disease before you know you're ill. So we recognize that most patients are actually shedding virus and are infective and contagious several days before they develop any signs or symptoms. We also know that based on data coming out of China and Italy, the West Coast, and now New York, that on average, patients are infected and asymptomatic for 5.1 days before demonstrating any signs of symptoms of illness. So really what that means is you're sick for 5 days before you know it, and you're spreading it. So given that it also takes about 7 days for people who develop signs and symptoms to become critically ill if they're going to, that means you're always 12 days better than you think you are. And the number I like to tell people is really what you have to think about is you won't know how you are today for 14 days. So if you're expecting to look around you and see the end effect or the demonstrable amount of disease burden in the area today, you can't see it for 2 weeks. And once you see it in 2 weeks, you can't change what you did today. So I would say that keeping up the messaging that yes, shutting down businesses was the right thing to do. And we know it's incredibly painful to all of us. We know that staying at home, and we know that hurting the economy, and we know that continuing to avoid many of the things that make us all happy, like seeing our families, going to religious services on Easter Sunday, things like that, hurt us, that they are the right thing to do. So I would keep up the messaging, and that is a fantastic question. So thank you for that. Let's get down to a question that is coming from Kim Rose. And the question is about correctional facilities. And I believe the question is, in the 3 populations you outlined, would incarcerated individuals fall? Would they be essentially within scope to come to this facility? That's question 1. Secondly, would incarcerated individuals meet a higher level of need when it comes to testing the presumptive positives due to the potential they have for bringing the virus back? So I think that nationally our experience so far with COVID has been that any place that you're closely confined is a hotbed for spreading disease. Think cruise ships, think schools, think any close space environment that doesn't have specifically designed ventilation systems to afford that. I do know currently, as we've designed the system, we would not have the ability to house people that are under the care of correctional facilities, primarily due to concerns of safety and security. We're actively thinking about how that would be done, but right now we do have concerns that would be very difficult to do. In regards to testing, I think a lot of correctional facilities that I've heard about, I don't have a lot of direct connection with correctional facilities, but what I'm seeing on the news is that they are attempting to self-isolate people in correctional facilities to the extent possible to try to prohibit spread. I do have concerns that will be difficult, and that is certainly a high-risk population. I did hear a news report yesterday, I think it was coming out of Illinois, that they weren't doing a lot of testing, primarily because the reality is testing oftentimes doesn't necessarily change the clinical treatment or management, but it certainly is designed to reduce the impact of spread. So if you have presumptive positive in cases in prisons, you could make the argument that all you'd have to do is self-isolate prisoners, and that may be the best countermeasure you can do. However, personally, as a clinician, I would like to see more testing, because more information always breeds better data. Those are great questions. Let me scroll down here, see if I can get to the next one. So let me time check. Yep, we're still good. So question is, how can Concord Hospital and the Capital Region best prepare for the next pandemic? So that's a great question. I think it is highly unlikely that we come out of the backside of this pandemic without a renewed emphasis on a PPE supply chain that is stateside. So we all have heard news reports of several million N95 masks going bad in California. I think that same experience probably occurred in many places, but were less talked about publicly. I'm not aware that happened in New Hampshire, however. I do think that we need to increase our ability to supply those critical things that we need. I think we also do need to think about how would we more stringently self-isolate index cases in the future. So what do I mean by that? And again, this is my personal opinion and not the opinion of my health system. if you look at what China did in reducing the spread in arguably a larger and more populated country, how they reduced spread is they actually self-isolated people together in facilities. They actually did rapid testing. They did aggressive use of testing, including CAT scans, and they placed patients into isolation together, realizing that if you send a positive person home to their family, the chances of additional cases, even in their own household, is relatively high. In the United States, we actually have very little capacity to be able to do that, but I do think we'll have to consider that as we come out of this. I also think that we have learned a lot of lessons about just having the kind of excess capacity. It could require to do this exceptionally well in the future to include in-house, inpatient, in-hospital capacity, ventilator surge supplies, as well as additional negative pressure rooms. So I think that my goal coming out of the backside of this is not to forget any of the lessons we've learned and to be a better health system for what we've learned during this very troublesome period. So next question is, what has Concord Hospital done to partner with other organizations to treat patients with COVID? So the answer is we've done quite a bit. So as I mentioned, this building I'm sitting in right now, this facility that we've stood up very quickly, was truly an interagency collaboration. I think everything that we've done has been interagency, and I think we have attempted to include community assets around us in providing for this challenge. Think Visiting Nurses Association, think the public health networks, think the state of New Hampshire. I think we do, however, after this, going back to the previous question, I do think we have to think about how do we do that even more effectively in the future, and how do we continue these surge plans in times of peace, so to speak, so that we're able to actually very adroitly pivot to this model when we need to. All right. Next question is a great one. Could Concord Hospital's family practice labor and delivery wards see a shortage of beds in the case the hospital sees a surge of COVID-19 patients that require hospitalization? The short answer is no. So the family place and the pediatrics units are two units that are absolutely protected from placing surplus COVID positive patients. We do have the capability and the capacity to take care of patients who are COVID positive who are in labor or being assessed for that. But we do not have plans to reduce capacity for labor and delivery due to the COVID crisis. This time of year is oftentimes the busiest labor and delivery season in our region, and we're sensitive to the fact that that's obviously an important thing. Again, that we must succeed in that mission. There's no opportunity to fail. Next question is, does the tech have space for healthcare workers, EMS workers, to isolate in the event they cannot do it at home? So the short answer is yes. I wouldn't say that we have comfortable spaces for people to live, but we actually do have space on the 3rd floor of Sweeney Hall for people to self-isolate should that become required. We also believe that patients and staff could self-isolate in Langley if we have capacity there, which would be more comfortable rooms if that becomes necessary. We do have a few rooms upstairs where staff who are working long hours could take a short break and rest before going back to work. However, we don't currently have the capacity for all of our staff to live on site. We are aware of, but are not currently ourselves coordinating efforts with local hotels and other external vendors to supply places for healthcare providers to stay if they need to self-isolate. But I am aware that there are some folks kind of working on that angle at the community level. So that's a great question. And the last question I've gotten so far is, will a prolonged period of isolation and stay at home actually make us more susceptible to other diseases going forward, since we'll be losing natural antibodies we get for just being around others? So in a way of thinking, that could be true. However, we do believe that actually self-isolation, social distancing, and containment measures are absolutely necessary. We do know that COVID-19 is a very, very infectious virus. And our experience with SARS and MERS previously indicate that if you can just get the virus to go away, if you can extinguish the epidemic or pandemic, the likelihood that that viral pathogen will not return is pretty decent. What we don't know is if COVID-19 will play by these rules and not return next fall. So I think all of us are familiar with the stories from the 1918 Spanish flu, in which there was a pandemic in the winter of 1918 that came back in the fall and further afflicted and caused further loss of life. I think we all hold some hope that if we can just contain the virus, flatten the curve, decrease the incidence of disease, that this could give us time to actually better prepare for this and perhaps even develop a vaccine that could be effective and could provide some immunity. I'm aware of at least 2 vaccine trials that are entering human testing with an expedited track, and I'm sincerely hoping that we could actually get a vaccine out before COVID-19 could come back in the fall, and that's assuming that it goes away in the summer. We don't yet know what COVID-19 will do, but it's a good question. It's a logical argument, but I do think that the risk is too high for us to just continue to expose ourselves and let the disease run its course. I know a few weeks ago, from the economic angle, some economists were making the argument, wouldn't it be better just to be done with this, to have a really bad month and get the economy back online? But I do think that the effect on the morale and perhaps even the spirit of a nation would be really devastating if we had the kind of loss of life we were predicting. I remember going back a couple months, there were predictions that there could be 20 million deaths in the United States. And now we're thinking that number could be under 100,000, maybe even 60,000, which I think for everybody who is saved a mortality statistic, this will be very, very worth doing. But that's a good question. That's something we could ask quite often. All right. So next question. When the immediate surge in stay-at-home orders are over, what do you think will be the next steps to contain local outbreaks? So oddly enough, I was listening to a podcast on my way to work this morning from the director of the CDC, and I agree with the CDC wholeheartedly that the strategy to contain further outbreaks is testing. Anytime someone gets sick, you need to test that person. You need to test people around that person, and you need to get those people isolated. If we can keep this disease out of large population centers, if we can keep this disease out of long-term care facilities, if we can keep it out of the healthcare worker population, if we can keep it out of people that serve in the capacity of lots of touches to other members of the population, that will be key to getting the backside of the curve to flatten out and go to zero. And I think honestly, our strategy going forward has got to be more robust testing. That's a good question. Next question is, will the hospital potentially have to furlough healthcare workers due to decreases in revenue from cancellation of elective surgeries and other appointments, as has happened at LRGH? I think what I would say is that the strain on New Hampshire healthcare systems is significant. We currently believe that the loss of revenue across the state is $250 million a month. This is certainly significant. This is being felt by all health systems, including our own. We are currently taking every measure we can to actually protect and be good stewards of our resources without furloughs. I can't specifically answer the question for the entire human resources plan, but I can tell you that we're doing everything we can to not have to do furloughs. I think everybody is aware there have been furloughs in some institutions around the state, and all I can say is I feel terribly for those institutions, because I know that they are doing what they can to do the right thing to make sure they can take care of patients in their facilities. These are going to be very difficult times for acute healthcare institutions.
I'm going to jump on. I have one more question for you actually before we end here. What can essential businesses do to protect their employees right now who cannot work remotely? Do you have advice on that?
Yeah, so that's a great question. So there's actually quite a bit of interim guidance on the CDC website. So if you go to cdc.gov, There's also quite a bit of good information for business owners at nh.gov/COVID-19. There's quite a bit of information there. I'd say the highlights are if you're around people and outdoors, wear a mask. If you can socially distance or physically distance yourself from 6 feet from other people, please do it. Please don't do anything in a public space that's not necessary. Be hyper vigilant for cleaning, use hand sanitizer like crazy. Wash your hands at least every 30 minutes or every 2 minutes if you can stand it. And just be careful. I would say the other thing is if you're sick, don't come to work. If you're sick, call your healthcare provider and seek guidance to see if you're a candidate for testing and protect those around you.
It's good advice. Yeah. All right. We have just a few minutes. Let me check to see if there's any additional questions here. Again, if anyone has a question, put it in that Q&A portal for us to take a look at. All right. Well, I'm so glad you were able to join us here today. Thank you again for taking the time to do that. I know you are incredibly busy right now, and Concord Hospital is working very hard to keep us all safe during this time. So, yeah.
Yeah, thanks everybody for jumping on. Be safe out there, be well. If you need us, we've got your back.
Anything else you want to add to share with our members and community members who are tuning in today that, to be aware of right now?
I think we covered most of it. I think I would stay tuned to guidance coming out from the Department of Public Health. I think I'd stay tuned to the messaging that comes out virtually every day from the governor. I think we're all kind of getting information as it comes out from state, regional, and local resources. The more that we pay attention and follow that guidance, the better off all of us collectively will be.
Yeah, I think that's great advice. So for everyone who's registered today, I will be emailing you a recorded version of this webinar, so you can go back and have access to this information, see what other questions there may have been answered that you missed. I'll also be sending some resources from the chamber of where you can find more information, and definitely use the Concord Hospital website and all of their resources as well during this time. All right, thank you so much, Chris, for joining us today. Really appreciate this wonderful information.
All right, be safe.
All right, bye.